They can then exit through the jugular foramen. Cranial nerve that is made up of several spinal nerve components. Traditionally, the cranial root of the accessory nerve, however, is actually part of
So why don't we
the
start
vagus
off with the
nerve.
external nose?
And if we look underneath here,
we already know that
we can
nose
see
is part
that the
of the
innervation for
respiratory
the
system,
sternocleidomastoid
and it is
comes from
responsible
its deep
to
surface,
aid us in
and then continues
olfaction,
on
so smelling,
this
in
fiber here
respiration,
that goes through the
filtration of
trapezius.
dust. This
So
individual
purely
actually does
motor
not have
to
very
these two muscles.
hairy
Do not
nostrils.
confuse any of the fibers that are going across the sternocleidomastoid here for parts of the accessory nerve, because they're not. This is, for instance, the great auricular nerve. This is a sensory nerve.
Men,
Okay?
especially
You have their
in aging
sensory
men.
nerve.
Well, in addition to
Again,
that, these
this
hairs
is
actually
probably
would help for the
transverse
filtration
cervical
of dust.
nerve, and then you have the lesser
Humidification
occipital
of the
nerve
inspired
right
air
here.
is very
There,
important. This is
lesser
why we actually
occipital
have
nerve.
several
So if you want to
shells
find this in
that
lab,
actually
my
arc
recommendation
into the
is,
inside of the nasal
after
cavity.
you
These are called
dissect away the
conchae
skin,
or
of
turbinates.
course,
We'll see
you
them a
cut
little
the
bit later on.
sternal
And of course,
the
there is
clavicular
also the
attachments
reception and
of the
elimination of
sternocleidomastoid,
secretions
and then
from
you
the
can
nasal
retract it,
mucosa,
pull it
the
superolaterally
paranasal sinuses,
until you then
and the
discover
nasolacrimal
on
ducts
its
that
underside
open
where the accessory
fairly
nerve dives
deep
into it.
into the
It's not that
nasal
hard.
cavity, into a region called the inferior nasal meatus. So the external nose, as we can see here, is kind of a hallmark feature or a very individual and a very unique distinguishing feature of us humans. Mainly the difference in size is largely due to the different size and shape, of course, of the nasal cartilages. The dorsum of the nose, which we can see up here, extends from its superior angle along the root of the nose all the way to the apex of the nose, and on the inferior surface of the nose we have these two openings, which are the nostrils or nares, or even you may call them nasal apertures. The lateral boundary of these, yes, of course, this also has a name. These are called the ala, or wings. Ala means wing. And the two halves of the nose on the inside are actually going to be separated by the nasal septum. We're going to have to remove
Last
some
but not
more
least, we have
tissue
the
layers until we can
hypoglossal
really
nerve.
see that.
The hypoglossal nerve
So
is
now we
entirely
removed a lot of the
somatic
soft tissue
motor.
structures. We
Two,
can now
all of the
have a look
intrinsic
at what are
and
actually the
extrinsic muscles
bony
of
parts
the tongue.
of the
With one
nose.
exception,
That would actually be our
the
nasal bones. There are
palatoglossus,
two of
as the name
those.
implies, was from the palate
Is the
down
frontal
to
process
the tongue.
of the
That is not
maxilla,
innervated by the hypoglossal nerve. That is
which
innervated
is
by the
this region
vagus
of the
nerve.
maxilla.
Okay. The
nasal
hypoglossal
part
nerve, as you
of
can
the
see
frontal
up
bone.
here, let me click on there. It actually originates
and
via
the bony
several
part
little
of the
rootlets
nasal septum, for
from
which we
the
have to
medulla,
dive into here.
and it leaves the cranium through
This part
its
of
own
the bony
dedicated
part of the nasal septum
canal,
is called the vomer, for
the
instance, and
hypoglossal
this one is
canal.
called the ethmoid bone.
There's the
Actually, this
hypoglossal canal,
part of
which
the
is
ethmoid
located
bone
in
will
the
be
posterior
perpendicular
cranial
plate.
fossa.
We'll have some more
After the
details
hypoglossal
as
nerve
we move
exits
along.
through the cranial cavity, let me see if I can show it down here.
And apart from
It
the bone, of
runs
course, the nose has a
inferiorly,
lot of
medial
cartilage
to the angle
associated
of the
with it as
mandible,
well.
and then curves
So we're going to
anteriorly
have
to
two
enter
lateral
the tongue.
cartilages.
In humans, there is
We're going to
additionally a
have
meningeal
two alar
branch that actually
cartilages.
returns back to the cranium.
And we're going to have a
And,
septal
well, it's called
cartilage.
meningeal branch, so what it does, it actually
And
innervates
here we go.
part of
Here
the
is
dura
our
mater
septal
on the floor
cartilage.
and on the posterior wall
As
of
you
the
can
cranial
already
fossa.
see
So
now,
it's sensory
the
innervation to
entire
that. However, that would be a
inside
contradiction
of
to
the
the statement
nasal
that the
cavity is going
hypoglossal
to
nerve
be
is entirely
lined
motor.
with mucosa.
No,
This
it's
is
not
very
really,
important because this
because
mucosa
the nerve
is always
fibers, they actually come
held
from spinal
moist, and
ganglia
also
from
we can
spinal
see here
nerve
are
C2,
these shelves or
not
these
from the
conchae that
hypoglossal
are
nerve itself.
arching
They just hitch a
in
ride.
and
It's an old story, we know that.
overlapping with each
Because
other
we
a
know
little
also
bit.
that coming
You have
off the
three of
hypoglossal nerve
those.
when
You
you go
have the
down
inferior
here
one, the
is
biggest
actually
one down
the
here.
ansa cervicalis,
Then
where
you
the
have a
nerve loop
middle
of the neck.
one.
It's
Let me
not
see if I can
indicated
get
here
it.
if you're wondering
Yep,
why you're not
here's the
seeing
middle
it.
one.
But
And
you
then
actually
even
have what's
higher
called
up,
the ansa
it'll probably be
cervicalis,
hard to
means
show
the nerve loop
with
of
the
the neck
software right
that
now.
is
There's going to
innervation
be
for
a
your
superior
infrahyoid muscles, for
nasal
instance.
concha as
If you
well.
want to test the
And these three
hypoglossal nerve,
shelves are
that's
there
pretty
to
simple.
help
This
increase
is
the
the one
surface
time
area
that you're actually
for
allowed
our
to stick
nasal
your tongue
cavity.
out at someone. So you ask the patient to stick the tongue out,
So here we get
straight,
to have a
or
look
try
at
and stick
the
it out straight.
olfactory bulbs
and
in a
if it
little
deviates
bit
to the
more
right or the
detail.
left, well, we know that
We
the
now have a magnified
genioglossus
view of the
muscles are
olfactory bulb, which
responsible
is in
for the
vivo, of course,
protrusion of the
located on the
tongue.
inferior surface of the
So,
frontal lobe,
if you have a lesion to
sitting
the
right on
right or
top of
left
the
hypoglossal nerve,
cribriform plates.
it will deviate,
So you have
and it will
one cribriform
deviate
plate on the left and one
towards the
on
side
the
of
right. In
the
between is
lesion,
this bony
right?
structure, the
So in
crista
normal
galli.
protrusion,
Interestingly, if I
the tongue will
click on
stick
these
out
little
straight,
labels here, you can see that the
because
olfactory
both
bulb is actually
pairs of muscles
going
will
to
contract
be
at the same
covered
time.
by
However,
pia,
if you have cranial nerve 12
arachnoid,
damage on one
and
side, like the
dura.
right side,
So all
the
three
tongue muscles there are
meninges,
going to
just
atrophy.
like the brain
So when you stick
itself.
out your tongue,
If I
it's going to
flip this
deviate
around, we can see a
towards
little
the
bit more
paralyzed
detail
so
of this
the
here.
right side.
And it also highlights the fact that the olfactory bulb is going to be the point where the olfactory nerve bundles will terminate and their central processes are going to coalesce. the olfactory nerve fibers that we can see going superiorly here to their respective sensory olfactory neurons. They're going to originate down here on this layer of sensory epithelium, which is olfactory epithelium, and it's covered in mucus. So if I click on here, you can see it's highlighted in green. That is the mucus covering the olfactory epithelium, and it is secreted by these mucus glands that we can see here. If we follow the olfactory bulbs posteriorly, that will be this end, then we can see that the olfactory tract, which would start right here at the posterior margin of the olfactory bulb. So this olfactory tract is going to run in parallel and on either side of the midline posteriorly, where it's then going to bifurcate and penetrate the brain as the olfactory striae. We're going to keep the details of the olfactory bulb to a minimum, as the lecture here is going to focus just on the gross anatomy of the nasal cavity. There are many more details for you if you click on the little icons. If you click on the labels within your software, you can click on a label and expand it, and it'll give you much more information here. So, in a nutshell about the function of the olfactory bulb, you probably know that the olfactory bulb is going to be fundamental to the process of smelling or olfactory transduction. It'll receive its neuronal signals about odorants via little odorant molecules that are going to be detected here by the olfactory sensory neurons. So that they can be detected, they actually have to first get absorbed into the mucosa, and then they're going to bind to these odor-binding proteins, which are within the mucosal layer of the olfactory epithelium. And once you have odorant molecules bound to their cognate receptor proteins, the information about this odorant is going to be encoded and subsequently transmitted to the olfactory bulb via the axons of the olfactory neurons. And this processing of the different odor molecules actually makes it possible for us to differentiate between different odors. So now I've made us a hemisected head that's supposed to help us illustrate the extent of the nasal cavity and also the differences between the nasopharynx and the oropharynx. Okay, so the nasal cavity technically will extend from the cranial cavity superiorly, which is up here, of course, to the palate inferiorly. So here's your hard palate. The soft palate would be posterior to that because, well, it's actually made up of muscle and, well, tendinous or fibrous structures. The oral cavity will then extend from the palate superiorly to the mylohyoid muscle inferiorly, which is the muscle that goes perpendicular here. It's perpendicular to the direction of the anterior digastric and the geniohyoid. And then we have posteriorly here where the larynx is, and do not ever make the mistake to say larynx. There is no reason to call this thing larynx, but especially in the south of the United States, people do make that mistake. So the larynx extends from the epiglottis, which is up here, all the way down to the cricoid cartilage, which is right here. The pharynx itself is going to be divided into three parts. There's the nasopharynx, which is basically the portion of the pharynx that you can see from here, which is the pharynx behind the nasal cavity. Then you have the oropharynx, and you probably already can tell that is the region behind the oral cavity, the oropharynx, and then of course the laryngopharynx, which is behind the larynx, so it is a little bit further down here. So the pathway for air would be entering the nose through the nostril or nares. We can see if we can kind of like go in here with the camera. You can see we are going to go past the nasal mucosa. This is where a lot of the humidification and the cleaning of the air happens. We don't have any hairs in this model, but there would actually also be hairs in here. So we would actually have the nasal cavity, and then let me zoom out a little bit. from the nasal cavity. Let's turn this around into the region of the nasopharynx. And have a look again here at the size of these shelves, the turbinates or conchae. See how far they actually protrude into the nasal cavity. Now just imagine a